Yeah, the NBRST study was a neoadjuvant study, not in DCIS, obviously, but in invasive disease. And in this neoadjuvant study, our question was about subtyping. Are we making the right choices in terms of preoperative chemotherapy treatment? Are we making the right choices, the choices that match up with the best outcomes? And so we've used subtyping all along, and it's an old-fashioned subtyping. Is the patient hormone receptor positive? Is the patient HER2 positive? And based on those classifications, triple negative or ER positive, HER2 positive or negative, we've sort of made the best judgment, and that patient has gotten neoadjuvant chemotherapy. We were suspicious that that did not really parse the patients in a way that was biologically relevant for a number of the patients. And so we used this 80-gene subtype called Blueprint. It's an 80-gene subtype that classifies patients into luminal or basal, which would correspond with triple negative to some degree, to a large degree, or HER2 positive. And what we found was very interesting. Patients who looked to be luminal by the old classification, they were hormone receptor positive and HER2 negative, about 20% of those patients reclassified as basal biology. And when we looked at those patients, the pathologic complete response rate was the same as it was for triple negative patients. And so what we suspect is that those patients are not being treated adequately, that they're getting inadequate treatment, and probably they need the same treatment we use for triple negative patients. But that study is very exciting in terms of, now we see in the 5-year outcomes, those basal patients have a much different outcome. They need much more scrutiny in clinical trials as a separate group. Even the HER2 positive patients by conventional criteria, either IHC or FISH, there is a subset of those patients who are basal by the subtyping assay, much different outcome and not as good. So we need to work on that group of patients too.